I am delighted to introduce Dr. Renato Martens as our next speaker. I know Renato as a superb clinician, deeply invested in the welfare of his patients, a creative thinker about potential new avenues of treatment for the patients he cares for. A native of Brazil, Dr. Martens trained in hematology oncology at the Massachusetts General Hospital and obtained his MPH from the Harvard School of Public Health. For more than a decade at the Seattle Cancer Care Alliance, he has led clinical trials to identify the best ways to take care of people who are living with lung cancer. He's a professor of medicine at the University of Washington and holds an endowed chair in cancer care because of all of his accomplishments over the past decade. However, to present a fuller and more accurate picture of Dr. Martens, I contacted his colleagues. And I learned that he's also a fierce squash player who has roundly defeated a number of the other faculty who were very happy to complain to me about this. He also engages in competitive stationary bicycling with hundreds of other riders across the country. And I have it on good authority that his name is often close to the top of the roster of these competitive cyclists. I also heard that he's burned over 100,000 calories last year in his competitive cycling. No, your wife did not tell me these things. I just want to get her off the hook. Thus, he's quite an athlete in addition to being truly a wonderful physician. So we are all looking forward to his talk tonight. Renato?
Thanks for the introduction. In fact, my wife, who is here, is actually a true avid cyclist. She qualified for a race this year where she rode 800 miles in 90 hours, and actually, obviously, got somewhere versus me, who just doesn't get anywhere when I ride. But it is true. I take it very seriously, the competition, and I have some interesting stories about that in my living room. Okay, so I want to talk about value in cancer care and how do we choose our health care. That has been an area that over the last couple of years I've been very interested in. And I think that that's a very important issue for us now. So let me start with a case. Imagine that you have a friend that develops a cough which does not get better over a 2-week period, and he sees the primary care physician, and a chest X-ray is performed. And many of you may or may not be familiar with the chest X-ray. This is obviously the right side. This is the left side. You have the shadow of the heart here. And what's abnormal here is that you have this shadow here, which shouldn't be there. So the primary care physician placed the patient on antibiotics, and the symptoms do improve, but appropriately so, the primary care physician then asks the patient to come back to document that that abnormality has resolved on the chest X-ray. And as it turns out, the abnormality has not resolved. So that needs further investigation. The primary care physician then orders a CT scan, and that's a CT scan. Everything that you see here on the right is on the right and left on the left. And as you can see here, there is a very large abnormality, something that should not be there. And it has an area of infiltrate around, which may explain why the patient got a little bit better with the use of antibiotics. So it's possible that there was a concomitant infection associated with this picture. Then the patient has a biopsy, which shows an adenocarcinoma of the lung, which is the most common type of lung cancer. Adenocarcinoma comes from the concept that this is a tumor originating from the glands of the lung. So I'm going to do something a little risky now, and that's to ask for audience participation. So, and if we don't have any volunteers, then I'm going to pick up people. So if you want to help the people around you, then please volunteer. So let's assume that your friend calls you and says, how can I choose the best place to have my lung cancer taken care of? What would you suggest? Do we have any suggestions? What?
Go to some place where they do a lot of them.
Excellent answer. And I'm going to come back to that in a minute. Okay, other answers? And by the way, there is no right or wrong answer here. You can say whatever you want. Any other suggestions? Get a second opinion, but let's talk about the first opinion. So where should you go first? Where should you get your care initially?
Well, poll your friends to find out
Okay,
if they know anybody who's done treatment.
excellent, excellent answer. What else? What?
Who had successful treatment.
Who had successful treatment, so a place they liked, that things went well. Okay? Google, exactly. You know, you put lung cancer, the first center that appears, that's where you should go. That's one option. I came up with a few suggestions. You could ask your friend to ask the primary care physician. He may have a recommendation. And I would say that most patients follow that pathway. Whatever the primary care physician tells them to get care, that's where they're going to get care. But you may have heard in the radio that this new hospital in town has a new lung cancer center, and that sounded pretty good. So that could be another option. Then one of the things that was said here, you know, you have a cousin who had surgery at hospital whatever, and had a really good outcome. So that's a good reason to go there, perfectly reasonable one. But also very common is that you have a friend who is a diabetes doctor, and you ask him to ask his friends where this person should get lung cancer care. So those are all very common. We hear those stories every day in our practice. I think that the first important question is, does it matter? I mean, are the outcomes so similar that you can actually get therapy anywhere and it really doesn't make a difference? You know, perhaps parking should be the deciding factor of where one should get care. I'll tell you that our administrator is justifiably so worried about parking. So I'm assuming that that's important. So the first person said something that I'm actually going to show here. Congratulations. Volume. So it does make a difference where you get care. So this is lung cancer surgery survival based on the hospital volume and outcome. So if you look at the lowest volume places that do between 1 and 8 procedures per year versus the higher volume places that do between 67 and 100, the absolute 5-year survival is 8%. That is a greater survival difference than you could get from giving chemotherapy to prevent the disease from coming back. That's how huge the difference is in terms of the volume of the place that you may decide to get care. So is the care itself similar? I think that Dr. Wood touched a little bit about that there are variations of care that are difficult to explain. We actually are doing a groundbreaking work at the University of Washington and the Fred Hutch. This is called the Hutchinson Institute for Cancer Outcomes Research. It combines data from cancer registry with insurance data. And I will show you the powerful of that combination in just a second here. First, this is the distribution of the cancers that are in this registry. And as you can see, because lung cancer is so common, you know, lung cancer is a very sizable percentage of that. Let me backtrack a little bit and give you a little bit of background for the next thing that I'm going to show. This is work done actually at Massachusetts General Hospital, where both I and Dr. Wood trained. What the investigators did here, they took patients with advanced lung cancer and they offered to them early palliative care. So they were getting whatever care they were supposed to get, but they also met with a team of physicians that were specialized in palliative care. And the primary outcome of that study was to evaluate if the patient's quality of life would be better, if they would get less chemotherapy towards the last days of their lives, which is considered a marker of poor care. If someone receives chemotherapy in the last week of their lives, you really are not doing a good job in caring for them. And their idea was that by having early palliative care, you would decrease the rates of chemotherapy towards the end of life, that they would die more on hospice. And in fact, that's exactly what they saw. So the group that had early palliative care had a 33% risk of receiving this care that we would consider inappropriate. Too much chemotherapy towards the end of life, not dying on hospice. While the group that did not have that intervention of palliative care, 54% of the patients had these interventions we would consider inappropriate towards the end of their lives. But what was surprising in that study was that the survival was a lot better if you did receive early palliative intervention. Well, that brings us back to the data from HiCor. Each one of these dots represent a place that provides cancer in the state of Washington. And they are not identified. In fact, not even I know who they are. But as you can see here, there is a huge variation on the administration of chemotherapy in the last 30 days of life. Different criteria use 14 days as inappropriate, other 30 days as inappropriate. There are places that provide care in the state of Washington that up to 50% of patients receive chemotherapy in the last 30 days of life. And then there are places that it's close to zero. So that's a huge variation of care. And this is the average for the state of Washington. 22% may sound higher, but here's the good news. We actually provide pretty good care here in the state of Washington, because I just showed you a couple slides ago that the intervention group at the Massachusetts General Hospital had a 33% administration of chemotherapy in the last 14 days of life. So actually, as a state, we do pretty well, but there is major variations in care. I can show you the data from the Seattle Cancer Care Alliance in the University of Washington. And here is the administration of chemotherapy in the last 14 days of life for the Seattle Cancer Care Alliance, 7.4%. That is an excellent number in comparison with everything that it's published nationwide. You know, it can never be zero because unpredictable things will happen. You think that the patient is going to do better, and then all of a sudden things go wrong. So that number is never going to be zero. But certainly, we would like the number to be as low as possible. So what information does one need to choose the right place to receive care? So when I explain this, I use this comparison. Buying a car. So this is a World News and World Report. You know, we talked about the rankings earlier today. I'm going to go back to that, but first let me show you the rankings in car buying. So here, they look at the average price paid, the cost of ownership, basically how much does it cost to maintain your car, and then they go to expert opinions of people that actually are going to sit in the car and drive it. And then they're going to evaluate a number of criteria in the car. How comfortable it is, how reliable, what are the safety features, and then they come up with a scoring system. So here's the last year's winner for sports car. That's the Volkswagen GTI. Since then, Volkswagen has reached a tough spot. So I expect that they wouldn't be winners this year. But last year, they got the winners for sports car, affordable sports car. Price between $24,000 and $31,000. Pretty clear. That's how much it costs if you want to buy the car. In fact, they go one step forward and say, average price paid. You know, it doesn't matter what was in the sticker. That's how much people paid for the car. And then they go on the overall scoring, and then they break down by the critics' ratings, performance, interior, safety, and reliability. This is another car. That's a Ferrari 458, which, quite frankly, I didn't even know that existed. But apparently, I think it was the car that, now I'm going to clearly say how old I am. I think that's the car that Magnum used in the show. And that costs $239,000. It's actually $239,340, which I always find amazing. 340? Yeah, why not 340? You know, the people look at this, okay, it's not 340, then I'll buy it. So the question is this a better value? Is the performance 9 times better than the Volkswagen GTI? Not likely, although I have never driven one, so I can't really speak from experience. Is the interior 9 times more comfortable than the Volkswagen GTI? Probably not. Is it 9 times safer? It's probably less safe because you may be emboldened by the power and then end up in trouble. And it's 9 times more reliable. No. So it's not a better value. There are many reasons for one to decide to buy a Ferrari, which have nothing to do with value, and I won't speculate on them, but certainly is not a better value price-wise. Okay, so now let's move to healthcare. This is the most recent ranking of cancer care places in the US, also by US News and World Report. So number 1 place, according to the US News and World Report, is MD Anderson. Number 2, Memorial Sloan Kettering in New York. 3, the Mayo Clinic in Rochester, Minnesota. 4, the largest of the Harvard hospitals, the Dana-Farber. As a coincidence, twice yesterday, I saw advertisement on national television, both for MD Anderson and the Dana-Farber. And number 5, us. Last year we were number 6, but we passed Johns Hopkins for number 5. And we are the number 1, according to US News and World Report, cancer center in the West Coast. So I'm in a very comfortable position to say that this is probably meaningless because it does not give you the information you really need. Let's look at an example of what I mean. The most important criteria is reputation. That's what carries the biggest weight. That's reputation among physicians. Physicians that, for the most part, had never gone to any of these hospitals. They have absolutely no experience how it is to be a patient in any of these places. Then they go into more objective criteria, for example, survival. Well, let's look at the Seattle Cancer Care Alliance survival. It's scored as a 10. Why? Because as it says there, our survival is much better than anywhere else. I would assume that that should be the most important thing that people should care about. You know, if I go there, will I come out alive? So, value in healthcare. Value is a concept of the health outcome divided by the cost of producing that outcome. This guy, Michael Porter, is a professor of management at Harvard Law School, and at Harvard Business School, and he is an international authority in management. Then he had a medical problem, and he had to go through the process of choosing where to get care, and he was horrified by it. How little information there was in terms of the outcomes for him to feel safe that he was getting the care in the best place versus all of these other criteria we talked about. You know, you speak with a friend, you have a friend that is a doctor, and then he will talk with his friend and then kind of go from there. He believes, and he's a very influential person, that measurement of outcomes and their reporting is the most important change that will happen in our healthcare system going forward. And I totally drank out of the Kool-Aid. I think that that will be a game changer. And when we talk about outcomes, we have to think about outcomes that matter to patients. In fact, on the US News and World Report, one of the outcomes that they follow is infections on catheters. That counts in there. If we were to ask around what outcomes matter to people here in this room, I suspect that infections from a catheter would never come up. This same group from Harvard put together an international consortium to look at this issue of outcomes and what can be measured and what can be reported to patients. This is the example of their lung cancer template. So for all patients, they believe that it's important to report how long does it take for you to find that you have cancer and actually be treated for it. I think that everyone would agree that that's an important thing, right? You don't want to be sitting around wondering what is going to happen with your cancer care. Then they go into complications of therapy. That matters to everybody, right? You want to have surgery, you want to get out of the hospital without any major complications. If I give you chemotherapy, you want to make sure that I'm not going to make your life worse by treating you with chemotherapy rather than better. Then for all patients, they also look at quality of life. So those are measurements of quality of life. You know, how functional will you be during your therapy? That matters to everybody. People want to live with cancer, not to be a cancer patient. And then obviously survival. That is absolutely key. You want to embark in this journey with the best possible outcome that can be achieved and be reassured that you're in a place that will produce that. And then there are issues of end-of-life care as well when that's appropriate, obviously. So the other side of the equation is the issue of cost. And the cost of cancer care, healthcare in general, certainly cancer care, is out of control. So this is predictions that in 2020, we're going to be spending $158 billion on cancer care. And that will be 27% more than we did in 2010. That can't keep going like this. We cannot afford that kind of growth. What about costs? Does cost vary from place to place substantially? So now we're going back to that data from HiCor, looking at different places in the state of Washington. And this is charges in the last 30 days of life for patients with advanced cancer. And as you can see, again, each of these dots represents a place where people receive care. As you can see, it can vary to as low as less than 15,000 to more than 30,000 in the last 30 days of life. And this degree of variation is very hard to justify. Why would that be? So let me go back to a case. Again, this is a CT scan. This is a patient that was a former smoker, and she presented with an advanced lung cancer that had not yet spread to other areas of the body, but it was too advanced to be treated with surgery. So she was treated with a combination of chemo and radiation therapy, which was actually a pretty aggressive treatment. So she went through that. Then she enrolled in a clinical trial of a cancer vaccine to try to prevent the cancer from coming back. As it turns out, that trial was a negative trial. It did not prevent from coming back, and certainly did not prevent from her cancer specifically to come back, because it did come back, and it came back in 2 areas that I selected here, among others. This is the adrenal gland. That's a gland that sits on top of the kidney. As you can see here, contrary to the other side, this one has a tumor sitting on it. Furthermore, there is a recurrence right at the entrance of the right lung as well, in another tumor. Then she received a therapy that stimulates her immune system to fight the cancer on its own. It's not chemotherapy. It doesn't destroy any other cells of your body. It stimulates your own immune system to fight the cancer on its own. The tumor's gone, and the tumor is gone. So she had a complete response to this treatment. And that's more than 2 years later. In fact, she remains in complete response, and she has completed last year 150-mile bike ride for fundraising to our cancer center, which is amazing. So, we're doing a lot better. And because we're doing a lot better, people are living a lot longer. That's great news. But because they're living a lot longer, they're also getting care for a lot longer than they used to be. That's also good news, but that's expensive. And we need to be stewards of the lung cancer cost and do what improves the outcome and stop doing the bunch of nonsense that does not improve patients' outcome. So now let's go back to your friend. Let's imagine a world where he would knew that lung cancer surgery in hospital X has an in-hospital mortality of 2%, while in hospital Y, this number is 4%. I think all would agree that that would be very good information to know when you make your decision about where to get care. Let's also imagine that every cancer center had to report what their 5-year survival after surgery is. And you knew that in hospital X, it's 55%, and in hospital Y is 51%. Let's say that 30 days after surgery in hospital X, and that piece is missing there, we knew that the patient was pain-free 90% of the time, while in hospital Y, they were pain-free 80% of the time. Most of the time, people prefer to be pain-free than not being pain-free. And finally, that the cost of care is not the same in the 2 places. And in hospital X is $38,000 to get lung cancer care, and in hospital Y is $41,000. I think it would make extremely easy to make the decision that you want to get care at hospital X. So, to conclude, the healthcare market is very imperfect. Unfortunately, patients do not have the information they need to make the decisions regarding their care. And this is changing, and I think that that's very good news for all of us. I think that in the near future, we are going to have outcome data that is available in a very friendly way to help us make healthcare decisions. And I will conclude with that. Thank you.
So Renato, that was an absolutely wonderful talk. I can see our series is off to a great start, and I'd like to ask the members of the audience, do you have any questions that you'd like to follow up on some of his points? Yes.
Well, thank you. That was enthusiastic and informative. Okay, so what are the driving forces that are going to encourage or require every cancer center to give uniform, non-biased, non-commercial information for whatever database you're talking about here?
Yeah, so there is something called value-based purchasing, and this is becoming really big at the government level. And you can criticize many aspects of government management, but that's actually a good one. There is a push that hopefully over the next, I think it's 2 years, that 50% of their payments will be value-based, which means that the payments will be different based on the outcomes that matter to patients. As, for example, getting out of the hospital sooner than later. The amount of time that one spends in the intensive care unit, so far and so on. I think that this train has left the station. We went into many variations of trying to control cost in the healthcare. One was this issue of capitation. I'll give you $50,000 to care for someone, and you can do whatever you want. Unfortunately, that leads to a race to the bottom. The incentive is not to do anything, because the less you do, the more you keep. That absolutely doesn't work. The other thing is to come up with very strict guidelines. You have to do this, then you have to do that, then you have to do that. And that is incredibly complicated. The reporting of it is incredibly burdensome from an administrative standpoint, so you increase costs tremendously, in an attempt to control cost. What makes much more sense is to say, yes, I will do X to take care of this patient, but you have to show that your outcomes are as good as other places, and you can do whatever you want. So from our standpoint as physicians, that's the holy grail, right? You want everyone out of your back so you can take care of your patient. So we would love not to have to obey to strict guidelines. However, that has to be in the context of reliable reporting of outcomes. Otherwise, we go to this race to the bottom, which would be disastrous.
So I'm just wondering on the outcomes, I agree with you that we all should have it, and maybe now, we're aware, and if we need care, we'll ask for it to your doctor or to the care facility, but it's like other things you didn't know you could ask, and maybe doctors and researchers have the data, but they use it when they're competing for dollars, or, but so it's more the awareness of putting it out there where it's easy to find, but first you have to ask the question so they know you want to know or that you're interested.
Yeah, so sometimes patients ask me, do you think that the doctor will be upset if I go for a second opinion? Or, do you think that the doctor will be upset if I ask A or B? And my general answer to that is, if your doctor is upset because you're going for a second opinion, you need a different doctor. In the same way, if the information is available, and I'm going to come back to that in just a minute, if you ask your surgeon, what's the 30-day mortality in this place for that surgery, they may not know, but if they do know and they don't want to tell you because they got upset with your question, you really need to have surgery elsewhere. The problem is that that information has not been required of physicians. I can tell you that I know what is the average survival of patients with advanced lung cancer that are treated in our center. By the way, it's 50% better than what's published in the medical literature. But that information is not widely available in other centers. And I suspect that if you were to ask at Memorial or MD Anderson, they may not be able to tell you. what their survivals are. So that's really a very important issue.
I have a question about the patient whose immune system was stimulated against the cancer. And I was just wondering how it was done, like were her immune cells taken out and primed and matured in a petri dish or something, or were they able to do this in vivo?
So this is a therapy that it's actually now approved for lung cancer. And again, talking about this issue of cost, it costs about $15,000 per month. What this therapy does is it's uncover the cancer cells to the immune system. Cancer cells are really smart. They have a way of turning off the immune system when the defense cells arrive at the cancer site. And what these drugs do is that they close that mechanism of turn-off. So the immune cells can actually see the cancer cell and destroy it. We cannot predict who responds to that yet, unfortunately. About 15 to 20% of patients with advanced lung cancer will have a dramatic response to these agents. And in some of them, it seems to be very durable. As it is in the case here, obviously, as you can imagine, this is a very vigorous person that is very involved in her care.
Another bicyclist, I believe.
Another bicyclist, exactly. And jokingly, she says, "What about now? Am I cured now?" And with each visit, and again, her cancer has not come back in more than 2.5 years. And I say, "You're never going to hear that from me, because that has never happened." And if you are the first person, it's hard to know what the chance that you're cured, right? Because there is no one ahead of you. And she was one of the first people in the country to get such treatment. So she is now 2.5 years without the disease manifesting itself. What does that mean? What's the chance she was going to get to 5 years? Who knows? When she gets to 5 years, then maybe we'll have a better answer to that. But
Can I make one brief comment? And I think Renato is illustrating the power of clinical trials. So she was one of the first people in this country to go on a treatment that is now approved. And so sometimes participating in clinical trials can get you forefront of treatment, and these treatments can be sometimes very, very helpful. So this illustrates how he's been very involved in developing new agents for cancer care.
yeah, I would say that contrary to when I was in fellowship, more years than I care to confess, we now have breakthrough drugs that are changing the landscape of lung cancer. And the most rewarding aspect of my clinical care job is the fact that we can offer these treatments to patients sometimes years before they are approved, giving them the opportunity to profit from these treatments way before they would otherwise. It's hard to predict one's outcome, but if that patient had not been enrolled in a clinical trial, considering how aggressive her disease is, she would never have ridden 150 miles because she wouldn't be here. So, for her, it changed everything.
I just had another question about that specific treatment. It really sounded like, from your description of it, it wouldn't even have a risk of increased autoimmune disorders. Is that correct?
Right. Questions here are great. Yes. Here's how I explain to patients when we discuss this therapy. It puts you press the gas pedal of the immune system to fight the cancer. But like in the Ferrari 458, I guess, sometimes the car goes a little too fast. And yes, in about 5%, perhaps a little more, patients can develop a severe autoimmune reaction, which really doesn't mimic the standard autoimmune reactions, but we have had cases of the immune system attacking the lung, attacking the liver, attacking the pancreas, and people can get pretty sick from it. But in the vast majority of patients, because that's all the drug does, regarding clinical trials, we've been extremely successful in the development of these agents. The first article published in our most prestigious journal had 3 authors from our group. And I tell the fellows that work with me that to be successful in clinical research, you need a little bit of luck. And the very first patient that we treated was a patient of mine, and she also had a complete response to therapy, which obviously increased our enthusiasm exponentially over a matter of months. And she would come in and tell me, I don't feel anything. Are you giving me anything? I mean, if the tumors were not getting smaller, I wouldn't know that I'm being treated. And I had never seen that before. So that was very impressive.
We have another question.
Yeah.
First of all, I want to say thank you so much for your time tonight. It was a very riveting presentation. And then my question was involving the clinical trials in which this bicyclist participated in. Where do you see the future of personalized medicine through genetic engineering for the next 5 to 10 years?
So, the biggest thing in cancer care right now is immunotherapy. And I think that we at the University of Washington are extremely well positioned for this challenge going forward. As obviously you know, the Fred Hutch and the University of Washington have a very long tradition of immunotherapy in the setting of bone marrow transplantation, in making your immune system fight the cancer. And I will say that one of the most rewarding things over the last 3 or 4 years in my career is that all these brilliant investigators from the Fred Hutch who had this passion for immunotherapy found out that lung cancer responds to it, and now they love us. So we're doing a lot of work in developing immunotherapy. I think we're just scratching the surface. Immunotherapy is going to get a lot better. I don't know if we're going to be curing lung cancer in my lifetime, advanced lung cancer in my lifetime. I hope that we're going to be making lung cancer into a chronic disease. That it's in check, you go live your life, and I'll see you in a couple months. I think that that is a possibility, and that's what we are working hard to achieve.
Okay. Well, thank you very much for coming this evening. This has been an inspirational evening, and thank you very much to both of our speakers who've shown us where lung cancer care is going.